Welcome to the deep dive. Today, we're taking a really crucial look at cardiomyopathies.
Yeah, diseases of the heart muscle itself.
Exactly. We've got some nursing education materials here, and our plan is basically to break down what these conditions are, their impact and the different types.
Kind of distill the key info.
Right. Think of it as getting a real handle on what happens when the heart muscle is the core issue. These sources give us a good foundation focused on fundamental understanding and patient impact.
And it's important to remember, cardiomyopathy isn't just one thing. It's an umbrella term.
Covering different problems with the heart muscle, the myocardium.
Precisely. Problems with its structure or how it works, or sometimes both. And they show up differently, but, ultimately affect the heart's main job, pumping blood.
Okay, let's dive in. First up, dilated cardiomyopathy, or DCM.
Right, DCM.
The sources say this is when the left ventricle, that's the main pumping chamber, right? Or maybe both ventricles get enlarged.
Yeah, they stretch out, get bigger.
But it's not just size, it's also function. The squeezing action is weaker.
Exactly. That's key. The systolic function is impaired. We measure this with LVEF, left ventricular ejection fraction.
LVEF, I've heard of that. It measures how much blood is pumped out with each beat.
Basically, yeah. A normal LVEF is, say, above 50%. In DCM, it often drops below 40 or 50%. That's a big drop in pumping power.
And this diagnosis, it comes after ruling out other common things.
Right. Doctors check for coronary artery disease, CAD,
Oh.
or significant high blood pressure, or major valve problems first. If those aren't the main cause, then they look towards DCM.
Makes sense. And it's a serious condition.
Oh, definitely. It's a major reason people develop heart failure, and unfortunately, it's a common reason for needing a heart transplant down the line.
So what actually causes DCM? What starts this whole process?
Well, the causes are pretty varied. For a long time, maybe up to half the cases were called idiopathic.
Idiopathic, meaning cause unknown.
Exactly. Just, we didn't know why it was happening.
Wow, half. That seems like a huge gap in understanding.
It was. But things have moved on. We now think a lot of those idiopathic cases actually have a genetic link.
Ah, so genetics play a big role.
A huge role. Estimates now are that maybe 20 to 50% of those previously unknown cases are actually familial or have a specific genetic cause. We found links to over 50 different genes.
50 genes, goodness. Any major players among those?
Yeah, one gene called TTN is a big one. It makes a protein called titin, which is crucial for muscle structure and elasticity. Mutations in TTN might account for up to a quarter of familial DCM cases.
Okay, TTN. What others?
We also see mutations in genes like LMNA, MYH7, SCN5A, and even genes related to desmosomes like DSP. Desmosomes are like the rivets holding heart cells together.
And how are these usually passed down?
Often it's autosomal dominant, meaning you only need one copy of the faulty gene from one parent to potentially develop the condition.
Okay, so that's the genetic side. What about causes that people acquire during their life, not born with?
Right, acquired causes. There are quite a few. Myocarditis is a big one, inflammation of the heart muscle.
Inflammation, often from infection.
Yeah, often viral. Things like Coxsackie virus, adenovirus, parvovirus B19, even HIV can trigger myocarditis that sometimes leads to DCM.
Toxins.
Yes, the toxins are definitely on the list. Chronic heavy alcohol use can cause alcoholic cardiomyopathy. Certain chemotherapy drugs, especially anthracyclines, are known to be cardiotoxic.
Chemo drugs. That's tough.
It is. Also, illicit drugs like cocaine and even heavy metals like lead or cobalt. The interesting thing, though, is that some toxic effects, like from alcohol, might be reversible if caught early and the exposure stops.
That's helpful. Any other acquired causes?
There's peripartum cardiomyopathy, PPCM, that occurs late in pregnancy or in the months after delivery.
Pregnancy related.
Yeah.
No.
And tachycardia-induced cardiomyopathy, where a really fast heart rate, if it goes on too long, weakens the muscle. But that one's often reversible, too, if you control the heart rate.
Good to know.
Then you have metabolic or endocrine issues, thyroid problems, diabetes, rare tumors called pheochromocytomas, nutritional deficiencies, too, like lack of thiamine or selenium.
So lots of different pathways.
Definitely. Autoimmune diseases like lupus can also be involved. And finally, ischemic cardiomyopathy.
It's ischemic related to blood flow problems, like
Right.
heart attacks.
Exactly. If coronary artery disease is the clear cause of the heart muscle damage and dilation, some classifications separate it out.
Yeah.
But it is the most common cause of systolic heart failure globally,
Mm.
and it looks very similar, a dilated, weak heart.
Okay, that's a huge range of causes for DCM. So fundamentally, what's going wrong inside the heart muscle? the pathophysiology.
Well, the core issue is that impaired systolic function. The ventricle doesn't squeeze effectively.
Right.
So more blood is left behind after each beat. This increases the volume and pressure inside the ventricle when it's trying to fill again. The end diastolic volume and pressure go up.
And the body tries to compensate?
It does initially. You get the Frank-Starling mechanism, and the muscle stretches more so it contracts harder, and neurohormonal systems kick in like adrenaline.
But that doesn't work long term.
No, it becomes maladaptive. The sustained stress leads to remodeling. The heart gets bigger, but it's a less efficient shape. The walls might thin out. It actually makes the pumping worse over time.
Maladaptive remodeling sounds bad.
It is. On the cellular level, if it's genetic, the mutations mess with how the muscle generates force. If it's inflammation or toxins, they directly damage the cells and trigger that same bad remodeling cycle.
Got it. Okay, let's shift gears then. The next big one is hypertrophic cardiomyopathy, HCM. How's this one defined?
So HCM is all about thickening. Left ventricular hypertrophy, the muscle wall gets abnormally thick.
Thickening. Okay.
And this is crucial, it's not just because the heart's working harder due to, say, high blood pressure or a tight aortic valve. It's a primary problem in the muscle itself.
So the muscle thickens on its own, essentially.
Pretty much, yeah. And the thickening is often asymmetric, not uniform. The interventricular septum, that wall between the ventricles, is a common spot.
The septum again?
Diagnosis usually involves measuring that wall thickness. Like 15 millimeters or more in adults is a typical cutoff. Or maybe 13 millimeters if there's a family history or a known gene mutation.
And what about the chamber size inside? Does that get bigger too?
Actually, no. That's a key difference from DCM. In HCM, the left ventricle cavity size is usually normal, or sometimes even smaller than normal because the walls are so thick.
Thick walls, small space inside. Sounds like that would cause problems filling.
It definitely does. That's often a major issue, diastolic dysfunction. And if you look at the tissue under a microscope, you see enlarged cells, yes, but also disorganized cells, myocyte disarray, and extra scar tissue, fibrosis.
Disorganized cells. And this one is mostly inherited.
Yes, HCM is the most common inherited heart disease, actually.
Inherited again. Are there subtypes of HCM?
There are. The main distinction is whether or not there's obstruction to blood flow leaving the left ventricle.
Obstruction caused by the thick muscle.
Exactly. That's obstructive HCM, or OHCM. The thickened septum narrows the outflow tract the path blood takes to get out.
Okay.
We measure a pressure gradient, a difference in pressure across that narrowed area. If it's 30 mmHg or more, it's considered obstructive. Often treatment like surgery is considered if it's 50 mmHg or higher.
And what causes that obstruction? Just the thick septum?
Mainly that, but it's often made worse by something called SAM, systolic anterior motion of the mitral valve.
Sam, what's that?
It's where, during the squeeze phase, systole, the front leaflet of the mitral valve gets kind of pulled or pushed towards the thickened septum.
So the valve itself adds to the blockage.
Precisely. It further narrows the exit path. This obstruction might be there all the time, at rest in maybe a third of people with OHCM. In another third, it only happens with exertion or certain maneuvers.
Like exercise?
Yeah, or things that change pressure, like straining.
Okay, so that's obstructive. What about non-obstructive HCM?
Right, NHCM. No significant blockage leaving the ventricle. But people can still have major symptoms.
From what then?
Mostly from that diastolic dysfunction we mentioned. The stiff, thick muscle doesn't relax and fill well. Also, sometimes they get ischemia, lack of oxygen to the heart muscle, even without blocked coronary arteries. And the pattern of thickening can vary too. Sometimes it's more at the apex, the bottom tip of the heart.
And cause-wise, you said HCM is mostly genetic.
Overwhelmingly. Usually autosomal dominant inheritance like DCM, but with really variable penetrance and expressivity.
Meaning?
Meaning even if you have the gene, you might not develop the condition or it might be very mild, while someone else in the family has severe disease. It varies a lot.
And which genes are typically involved?
In about 60% of cases, we find a mutation in a gene for a sarcomeric protein.
Sarcomeric proteins. Your contraction machinery, I guess.
Exactly. The big players here are MYH7, beta-myosin heavy chain, and MYBPC3, cardiac myosin binding protein C. Mutations in just those two account for maybe 50 to 75% of the cases where we find a gene mutation.
So faulty contraction proteins, how does that lead to the thickening? It seems counterintuitive.
Yeah, it's complex and still being researched. One leading idea is that these mutations actually cause hypercontractility.
Contracting too much.
Sort of, yeah.
Yeah.
Or maybe more accurately, they make the contraction process less efficient or alter how the muscle handles calcium. It might increase the activity of enzymes involved in contraction or make the muscle overly sensitive to calcium.
So working overtime in a way.
And inefficiently.
Yeah.
It uses more energy. Plus, this state seems to trigger signals that lead to the muscle cells getting bigger, the hypertrophy, and that myocyte disarray, the disorganized structure, messes up electrical signals too.
Leading to arrhythmias.
Potentially, yes.
Okay, we've covered DCM and HCM in some detail. Let's pull back a bit. What's the overall impact of cardiomyopathies generally?
It's pretty substantial. A big global health burden, lots of illness, reduced quality of life, and unfortunately, mortality.
And the main consequence seems to be heart failure.
Absolutely. That's the most common, most significant outcome. Whether the heart's dilated and weak, like in DCM, or thick and stiff, like in HCM, eventually it often struggles to pump enough blood for the body's needs.
Leading to those classic heart failure symptoms, shortness of breath, fatigue, swelling.
Exactly. And fluid retention, edema, heart failure due to cardiomyopathy is a huge reason for hospital stays and really diminishes quality of life.
What about other major risks? You mentioned arrhythmias.
Yes, definitely. The risk of cardiac arrhythmias and sudden cardiac death, or SCD, is higher.
Why is that?
Well, all that remodeling, the thickening, the scarring, the disarray, altered electrical signals, it creates an unstable electrical environment in the heart.
Makes it prone to short circuits, basically.
Kinda, yeah. You can get atrial fibrillation, which increases stroke risk, or worse, ventricular arrhythmias, ventricular tachycardia, ventricular fibrillation.
And those can cause sudden death.
They can. That's what SCD usually is, a fatal arrhythmia. The annual risk might be relatively low, say 0.15 to 0.7% in some groups, but it's much higher than the general population, and a major concern, especially in younger people with certain types like HCM or ARVC.
That's incredibly serious. Any other complications?
Yes. Blood clots can be an issue, especially in dilated hearts where blood flow might be sluggish. Clots forming inside the heart.
And they can travel, cause strokes.
Exactly. Thromboembolism risk goes up. Also, the structural changes can distort heart valves, making them leak, mitral regurgitation, tricuspid regurgitation. That puts even more strain on the heart.
It sounds like it really impacts daily life.
Hugely. Symptoms limit activity. Plus, the chronic nature, the fear of SCD, it takes a toll mentally too. Anxiety, depression are common. Quality of life definitely suffers.
And I imagine there's a cost to society as well.
Oh, for sure. Huge socioeconomic burden. Healthcare costs are high meds, devices like defibrillators, hospital stays, maybe even transplant. And then there's lost productivity.
People missing work.
Yeah, or unable to work. Especially since these conditions can affect younger, working-age people. Studies show those indirect costs are a massive part of the economic impact, particularly for people with more severe symptoms.
So how common are these conditions? Are they rare?
Not really rare, no. But getting exact numbers is tricky. They affect all sorts of people, all ages, sexes, ethnicities, but prevalence varies.
Why is it hard to get exact numbers?
Well, the conditions are diverse, presentation varies, some people are asymptomatic for years, and diagnostic criteria have changed. So there's likely some underdiagnosis happening.
Okay, but what are the current best guesses for prevalence?
For HCM, the most common inherited one, maybe 1 in 200 to 1 in 500 adults. Could even be higher, like 1 in 67 if you count milder cases.
1 in 500, maybe even 1 in 200. That's quite common.
It is. For DCM, estimates range a bit more, maybe 1 in 250 to 1 in 2,500. But recent data leans towards the 1 in 250 figure. Incidence is maybe 5 to 8 new cases per 100,000 people per year.
Okay. What about the others?
RCM, restrictive, is least common, maybe 2–5% of diagnoses. ARVC, the right ventricular one, perhaps 1 in 1,000 to 1 in 5,000. LVNC, left ventricular noncompaction, harder to pin down overall, but maybe 4% of kids' cardiomyopathies. And PPCM, the pregnancy-related one, around 1 in 1,000 to 1 in 4,000 births in the U.S., and maybe rising.
It really adds up. Do these affect different groups differently? Age, sex, race?
Yeah, there are patterns. Age, ARVC and HCM often show up in teens or young adults, hence the SCD concern there. DCM is more common between 20 and 60. RCM varies genetic forms younger, acquired like amyloidosis older. Takotsubo, mostly postmenopausal women.
And sex differences?
Inherited ones like HCM or RVC have equal genetic risk, but males might get diagnosed more or have more severe disease sometimes. DCM also seems more frequent or severe in males. Takotsubo is overwhelmingly women. PPCM is only women. Lots of reasons. Hormones, maybe diagnostic bias, healthcare seeking. It's complex.
What about race and ethnicity?
Some significant differences there. DCM risk is maybe 2.5 to 3 times higher in black individuals versus white individuals. RCM, due to sarcoidosis, is most common in black women. HCM prevalence seems similar across races, but maybe outcomes differ. PPCM seems more common and perhaps more severe in women of African descent.
Why these disparities?
Likely a mix of things. Genetics, socioeconomic factors, healthcare access, environment. It's rarely just one factor.
So summing up risk factors, genetics is big for some types. What else?
Right, family history is key for inherited forms. And then there's a lot of overlap with general cardiovascular risk factors. Right. Hypertension, diabetes, obesity, high cholesterol, smoking, heavy drinking, illicit drugs, cocaine, steroids, sedentary life, poor diet.
Standard heart health advice seems relevant then.
Very relevant for prevention or mitigation of acquired types.
Yeah. Then there are underlying conditions.
Existing coronary artery disease or prior heart attack, infections like viral myocarditis or even COVID-19 now, inflammatory diseases like sarcoidosis or lupus, infiltrative diseases like amyloidosis, thyroid issues, neuromuscular disorders, pregnancy issues for PPCM, exposure to toxins like chemo, radiation, and severe stress for Takotsubo.
It's a long list. Really highlights how many things can impact the heart muscle.
It does, and underscores why managing those modifiable risks, blood pressure, diabetes, lifestyle, is so important, even if you can't change your genes.
We've mentioned genes and proteins a lot. Can we briefly touch on the cellular and molecular stuff again? What kind of proteins are affected?
Sure. It boils down to mutations affecting protein function. We talked about sarcomeric proteins in HCM, DCM, RCM, the contraction engine, dedosomal proteins in ARVC, the cell-to-cell anchors.
Right.
Cytoskeletal proteins like titin, and nuclear envelope proteins like lamin AC, often in DCM, affecting structure and force transmission. Even ion channels sometimes, disrupting electrical signals but also causing structural issues. And proteins involved in metabolism, how the heart gets energy.
Can you give a quick example again? Sarcomere dysfunction in HCM.
Yeah, in HCM, the mutations often lead to that hypercontractility and poor relaxation, maybe by making the muscle too sensitive to calcium. It contracts hard, but doesn't relax well.
And desmosomes in ARVC.
Weaken connections between cells. They detach, die, get replaced by fat and scar tissue. Plus, these proteins are involved in cell signaling pathways like WANT and Hippo, which get messed up and contribute to that replacement process.
And DCM again, titin and lamin?
Right. Titin mutations affect force transmission and structural integrity. LAM AC mutations affect the nucleus structure and can also cause conduction problems, arrhythmias.
And you mentioned common threads like calcium and energy.
Yeah, problems with calcium handling, how it's released, stored, removed, are super common, leading to weak contraction, poor relaxation, and arrhythmias. And impaired energy metabolism, the heart being starved for energy, is another frequent finding across different types, making everything worse.
And this all ties into that concept of remodeling you mentioned earlier.
Exactly. Remodeling is the heart changing its size, shape, structure, function in response to all this stress or injury.
Starts as adaptation, becomes maladaptive.
Precisely. Initially tries to cope, but long term, the changes hurt more than they help, leading towards heart failure.
What are the key features of that remodeling?
Things like pathological hypertrophy, like in HCM, ventricular dilation, the stretching in DCM, myocardial fibrosis, that scar tissue buildup causing stiffness and electrical problems. Inflammation plays a role. Cardiomyocyte death, losing muscle cells. Myocyte disarray in HCM. And that overactivation of neurohormonal systems like RAAS and sympathetic nervous system, which becomes harmful over time.
All interconnected, driving the disease forward.
Yeah, it's a complex interplay.
We focused on DCM and HCM, but our outline mentioned a few others briefly. Can we quickly cover those? Restrictive cardiomyopathy, RCM?
Sure. RCM, stiff, non-compliant ventricle walls, impairs diastolic filling, how the heart fills with blood. Size and thickness might be normal initially, these common type, caused by things like amyloidosis, sarcoidosis, fibrosis, sometimes unknown.
Okay. Arrhythmogenic right ventricular cardiomyopathy, ARVC.
ARVC or ACM mainly affects the right ventricle. Muscle replaced by fat and fibrous tissue, leads to structural problems, electrical instability, high risk of ventricular arrhythmias, strongly genetic, often those desmosomal protein mutations.
Got it. Left ventricular non-compaction, LVNC.
LVNC. Distinct look on imaging excessive trabeculations, like a spongy appearance inside the left ventricle with a thin, compacted outer layer. Can be genetic or acquired.
Peripartum cardiomyopathy.
PPCM.
PPCM. Heart failure towards the end of pregnancy or months after delivery. Cause is likely multifactorial, not fully understood yet.
And Takotsubo cardiomyopathy.
Takotsubo, or stress-induced. Sudden, temporary weakening of the heart muscle, usually triggered by intense emotional or physical stress. Often see that characteristic apical ballooning shape of the left ventricle.
Wow, quite a spectrum of conditions. So let's try to wrap this up. Key takeaways from this deep dive. I think the main things are cardiomyopathies are diverse diseases directly affecting the heart muscle. They have a major impact heart failure, arrhythmias, SCD risk. Different types exist with distinct features, like DCM's dilation versus HCM's thickening, and often genetics and complex cellular mechanisms are involved, leading to that harmful remodeling process over time.
And this overview, based on these nursing education materials, gives us a solid foundation. Hopefully, listeners feel they have a better grasp now on what it means when the muscle itself is the problem.
Yeah, distinguishing it from, say, artery blockages or valve issues, a different category of heart disease.
So, thinking about all this, the genetics, the lifestyle factors, the different ways these diseases show up, it really makes you wonder, doesn't it? What other questions come up? Maybe about how these factors truly interact, or about specific types, or perhaps where research might be heading next to tackle these conditions.
Absolutely. It's a field with so many layers still to uncover. Considering that intersection of our genes, our lives, and our heart muscle health, there's a lot to think about.
It's definitely food for thought. Hopefully, this dive has sparked some curiosity for further exploration.
Indeed. And understanding these fundamentals is the first step towards appreciating the complexity and the importance of addressing cardiomyopathies.